Hello, shall we start? Or shall we wait for a few more minutes? Hello.
No, sir.
Shall we wait or start?
Start, sir.
Okay. Okay. Today we'll learn about basics of epilepsy. Next slide. Before we are going to in detail about seizures, let us know the basic terminologies like what are the seizures, what are the convulsions, and what is epilepsy. Am I audible? Hello.
Yes, sir. Yes, sir. Audible, sir.
Audible. Okay. First, we'll come to the definition of the seizures. Seizures are nothing but excessive and synchronous electrical discharges in the group of cortical neurons. It may be self-limiting, or it may be subclinical, or it may be non-convulsive also.
Okay.
Next, it's just an electrical activity. Convulsions are nothing but body movements due to the co-contraction or rhythmic contraction of agonist and antagonist movement. The rhythmic or co-contraction of rhythmic or co-contraction of the agonist or antagonist muscle that is leading to the muscular movements. So it can be used interchangingly with the seizures, and many types of many types of convulsions are also defined, which may be subtle or which may be having some mild symptoms. Next step, next slide. Let us come to the definition of epilepsy. What is epilepsy? It is a medical syndrome, constellation of recurrent unprovoked seizures. The following mentioned is the definition of the epilepsy, in which there are two or more unprovoked seizure. Unprovoked means there are no definitely elicited or definitely identified cause. Like that, in provoked seizures, hypocalcemia, hyperglycemia, uremia, structural mass lesions, all will come under the provoked seizures, where you can find out the cause for seizures. Here, in the epilepsy, if any unprovoked seizures, two unprovoked seizures of duration of more than 24 hours, or one unprovoked seizure having the recurrence rate of at least more than 60% of recurrence of the seizures within a span of 10 years. Like we can use the seizure risk calculator score, in that the reoccurrence rate, if it is more than 60% over the period of next 10 years, that term also considered under the epilepsy. And third one is epileptic syndromes like Dravet syndrome, Lennox-Gastaut syndrome, Lando-Klempner syndrome, West syndrome. All those epileptic syndromes will also come under epilepsy. In these following three definitions, in these 3 points, any one of, if a patient is having any one of the symptoms or one of the mentioned point, you can label it as epilepsy. Any doubt in this definition?
No, sir.
Okay, next slide. So terminologies and classifications are very important. As all of you know, initially we used to use the term partial seizures, complex partial seizures, secondary generalized seizures, and localization related epilepsy, idiopathic epilepsy, cryptogenic epilepsy, scar epilepsy, symptomatic epilepsy. All these terminologies are outdated. Recent terminologies are for partial seizures, it is focal seizure; for simple partial seizures, focal aware seizures; for complex partial seizure, focal impaired awareness seizure. The secondary generalized seizure we can call as focal to bilateral tonic-clonic seizures. Okay, and for localization related epilepsy, newer terminology is focal epilepsy. Idiopathic generalized epilepsy can be called as idiopathic or genetic generalized epilepsy. Cryptogenic epilepsy is renamed as epilepsies of unknown cause. Symptomatic epilepsy, as we routinely write, don't write the symptomatic epilepsy as the diagnosis. We can write as structural epilepsy, metabolic epilepsy, or other conditions that are associated with the etiological agent. And benign epilepsies are named as self-limited or pharmacoresponsive epilepsies. If the cause or if the onset is unknown, that time we can write as combined generalized or focal or unknown onset generalized tonic-clonic seizures. As all of you know, these old terminology, simple, complex, all those things are outdated, and terms which are no longer used are complex partial, simple partial, partial, dyscognitive seizure, secondary generalized tonic-clonic seizure. You should not use these terms. Okay, only the table which has given the recent ILAE classification, the International League of Epilepsy classification 2017, completely changes the previous terminologies. You should use these terms only: focal seizure, focal aware seizure, focal impaired awareness seizure, focal to bilateral tonic-clonic seizure, or unknown onset. These terminologies you should be used. Okay, previous these terminologies you should not use in the diagnosis part, or whenever you are documenting the seizures, you should not write the previous terminologies. Okay, any doubt in this slide?
No, sir.
Okay, next slide. Next slide. Okay, this is the recent classification, International League Against the Epilepsy 2017 classification. The first one is basic version, second one is expanded version. In basic version, broadly they classified seizures or epilepsy as focal onset, generalized onset, and unknown onset. In again focal onset, you can write as focal onset aware seizure, focal onset impaired awareness seizure. In focal epilepsy, again you have to classify as whether patient is having awareness during the attack. That is, patient is he is able to recognize or he is able to remember the event. That is called aware seizure. If he is not able to remember the event, that is called impaired awareness seizures. Again, focal epilepsies are classified as motor onset and non-motor onset. In motor onset, you can say as tonic, clonic, myoclonic, atonic, automatism. All those come under the motor onset. In non-motor onset, sensory symptoms, all those sensory symptoms, cognitive symptoms, emotional, autonomic symptoms will come under the non-motor onset symptoms. And last one is focal to bilateral tonic-clonic. If the epileptic focus or if the symptoms start with the one side of the body, that is focality, then gradually progress to other side, that is focal to bilateral tonic-clonic. In generalized, again, you can divide it as motor and non-motor. In motor, again, tonic-clonic, myoclonic, all those things will come. In non-motor, absence seizures will come. Okay. And third one, if the onset not known to the patient or any attenders or the doctor, like if you are not able to find out whether onset of seizure is focal or generalized, that time we can label it as unknown onset, motor or non-motor symptom. Next slide. This is the first one is the basic version. Next one is the expanded version. That is same as that previous I mentioned. In motor, there are automatism. Can anybody define what are the automatism? Definition of automatism?
Hello, sir.
Anybody can try?
For the performance of action without conscious thought or intention.
Okay. These are the repetitive or stereotypic motor movements which are involuntary, that are called in automatism. Say for an example, a patient having the movement of lip smacking and spitting, oromandibular movements, all those motor movement which appears to be looks like voluntary movement but actually which are involuntary, that are all called automatism, mainly seen in motor onset focal seizures. Okay, automatism. Atonic, clonic, epileptic spasms, hyperkinetic seizure. Can anybody tell what are the hyperkinetic seizures where you will see? Okay, hyperkinetic are nothing but excessive motor movement like pedaling, kicking, thrashing movements, which are usually seen in frontal lobe epilepsies. Sometimes we miss as psychogenic seizures or functional seizures. Okay, hyperkinetic seizures also motor onset, myoclonic seizures and tonic. All these come under motor onset seizure. In non-motor onset, autonomic, like sweating, palpitation, and piloerections, all those things will come under the autonomic. Behavioral arrest, sometimes patient will have behavioral arrest. He cannot able to, or person, those who having epilepsy, focal epilepsy, sometimes cannot able to talk, cannot able to recognize the surrounding. That is called behavioral arrest. Cognitive problem like memory disturbances, emotional imbalance, or sensory symptoms, all are come under the non-motor symptoms. Again, in generalized onset, you have motor and non-motor. Motor is same as that I told earlier, and non-motor absence epilepsies will come under the non-motor part of the generalized epilepsies. In that, absence epilepsies again classified as typical, atypical, myoclonic absence, and absence with eyelid myoclonia. Okay, if patient will eyelid with eyelid myoclonia of the absence means patient will have just brief myoclonic movements involving the eyelids, then patient will start having the absence like episodes. And unknown onset, same, like if the initial focality or initial symptom of the seizure, if nobody knows, that time you can label as unknown onset seizures. Okay, again it has been classified as motor and non-motor part. In non-motor it is behavioral arrest, in motor same, tonic, clonic, and epileptic spasms are come. Okay, any doubt in this slide? This is the recent classification, LAE classification. According to this only we need to write the diagnosis, we need to define the epilepsy or seizure focality. Any doubt in this slide? This is very important.
Sir, what is
Okay.
behavioral arrest, sir?
What?
What is behavioral arrest, sir?
Behavioral arrest means patient will be stuck, not able to identify, not able to talk for few seconds to few minutes. Initial stage of focal motor seizure, focal seizures. That time patient will not able to identify, will not able to talk.
Okay.
Complete blackout, like he's not able to remember also, he will not able to talk, he will not able to understand the spoken words.
Okay, sir.
Okay. That can also be focal seizures. Okay. Next slide. So, okay, why so much emphasis on the classification? Because it will help to identify the focality of the seizures. So whether we can decide the seizure medications, because all spectrum of these all type of epilepsies will have different type of anti-epileptic groups. Same, for example, if focal epilepsy is are there, that time you can give carbamazepine, oxcarbazepine, lamotrigine will help more. If generalized epilepsies are there, valproate, lamotrigine, levetiracetam will help more. If patient is having myoclonus, that time valproate, levetiracetam, clobazam will be better options. If patient is having infantile spasm with tuberous sclerosis, that time vigabatrin would be the better choice. So we can choose the anti-seizure medication according to the type of epilepsy, and according to the type of epilepsy we can investigate the patient whether to do blood investigation or imaging or EEG or PET scan. All those things can be planned according to the type of epilepsy or seizure patient having. And if refractory epilepsies are there, if we get the any focality, that time we can plan for epileptic surgeries also, and we can explain the prognosis to the patient, and we can fit the epilepsy into the particular syndrome groups depending on the laboratory findings and the clinical evaluation. So this classification is very much important. As all of you should know the classification of recent classification of epilepsy, ILAE 2017. Next slide. Okay, let us come to these terminologies one again. Focal seizures, in which the focality which will begins with the particular part of the cerebral cortex. Previous slide. Okay, in focal seizures, previously known as partial seizure, in which it will start with the particular area or network of the cells which are present in the one side of the brain. In generalized seizures, it will engages or it will involve the networks of the both side of the brain. Primary, it is also called primary generalized epilepsies. In unknown onset, if the onset of the seizure is not known, the seizure falls into the unknown onset category. Later on, it may evolve to occur as generalized or focal. Later part, we can label it. So if initial part of the diagnosis, if you don't know the particular onset of the epilepsy, you can label it as unknown onset. And focal to bilateral seizures, in which seizures will start from one part of the brain, gradually progress to involve the other part of the cortex. So it will be generalized to other side. So these generalized terminologies is eliminated. You can use focal to bilateral seizure, like focal to bilateral tonic or focal to bilateral tonic-clonic seizures. So don't use the term secondary generalization. Seizure with secondary generalization, you should not use the term focal to bilateral tonic-clonic or focal to tonic-clonic or focal to clonic, whatever the type of seizure patient is having. Next slide. Then describing the awareness. This is the new terminology which is used in the ILAE 2017 guidelines. That is focal seizures classified as focal aware seizure and focal impaired awareness seizure. In aware seizure, patient will have intact awareness, but he cannot able to, sometimes he cannot able to talk and he cannot able to respond, but he is aware what are the things which are happening around surrounding. He can able to tell after the seizure event stops. Okay, in focal impaired awareness, patient will not be aware of the attack which has happened prior. That is called focal impaired aware seizure. Focal aware seizure is previous terminology was simple partial, and focal impaired aware seizure was complex partial seizure. Any doubt in this? This is very important. Any doubt in focal aware and focal impaired awareness seizure?
No, sir.
Okay, next. Okay. Again, motor seizures. Next slide. Motor seizures has been classified as focal motor, and focal non-motor onset seizure. In motor onset, as all of you know, twitching, jerking movement, stiffness, dystonia, hyperkinetic movements, myoclonus, epileptic spasm. These are all the motor part of the focal epilepsy. In non-motor part, that sensation, emotion, thinking, experience, autonomic symptoms, behavioral arrest, cognitive symptoms, all those things will come under the non-motor symptom. And aura, this is also very important. It also indicates the focality of the lesions. If aura is there, epilepsy most of the time belongs to the focal epilepsy, whether it may be temporal lobe epilepsy or occipital lobe epilepsy or frontal lobe epilepsy. It is used to describe the symptoms a person may feel in the beginning of the seizure. These symptoms may be the part of the starting. These are the early symptoms which occur just before onset of the seizures. These are nothing but simple partial seizures. Most common things are paresthesias, jerking movements, epigastric discomfort, fear, unpleasant smell, psychic experience like deja vu and jamaisu. All those will come under the auras. Next slide. Jacksonian march, this is the previous terminology, as all of you know. Abnormal movement that may begin with a particular area of the cortex, like involving the homunculus representation of fingers, that gradually involve the other parts of the body over a period of seconds to minutes. This is a classical of focal epilepsis with bilateral tonic-clonic generalization. And Todd's paralysis, sometimes patient may experience localized paralysis for a minute to many hours in the involved region following the seizure. As all of you know, Todd's paralysis is also one of the close differential diagnosis for stroke also. Okay. Can anybody tell for how many days it will persist? Maximum days? Todd's paralysis? Can it involve facial muscles? Can it involve cranial muscles? Or only limbs? You might have seen many number of cases. Post seizures, Todd's paralysis.
Maximum till 36 hours.
No, it can persist up to 7 days also. As textbook defined, up to 7 days. It can involve facial muscles also. Facial paralysis also, sometimes if patient is having seizures involving the facial muscle innervation, the patient will have persistent facial deviation for sometimes up to the 7 days also. So after doing the imaging only, you can rule out the stroke or seizure with Todd's paralysis. Okay. Next slide. Okay, let us come to the individual type of seizures. Generalized seizure, all of you know, is the main seizure type due to the involvement of contraction of muscles of agonist and antagonist. If both are contracted, patient will have tonic movement. If rhythmically one group contraction, one group relaxation, that will lead to the clonic movement. That is generalized tonic-clonic. Initial part will be contraction of muscles that will causes the tonic movement of all the bodies associated with sympathetic cells. Later part will be the clonic phase in which muscle contraction, relaxation that will lead to clonic movement of the hands or limbs. And later part will be postictal phase in which patient will be unresponsive for a 15 to 30 minutes associated with the muscle hypotonia and sometimes salivation, bowel and bladder incontinence. Next slide. So some of the clinical clues you can differentiate generalized from focal seizures. Aura, automatism, head version movement, clonic movements will be most commonly seen in focal epilepsies. Prodrome, complete loss of consciousness, prolonged postictal confusion, and generalized tonic-clonic seizures are classical of generalized epilepsies. Okay, these are the few terminologies you should be remembering, because way of treatment and way of management of focal epilepsies and generalized epilepsies will be entirely different. So clinical history would be very important to identify whether patient is having focal epilepsy or generalized epilepsy. Next slide. Again, this is the same, like generalized seizures, generalized tonic-clonic seizure, tonic seizure, clonic seizures, absence epilepsies, myoclonic epilepsies, atonic epilepsies, and infantile or epileptic spasms. All these are come under generalized seizure group. Okay, next slide. So as all of you know, typical absence seizure. Absence means like a sudden brief lapse of consciousness without loss of any partial tone. Usually age group would be between 3 to 12 years, last within few seconds, and without any involvement of motor movement. Sometimes eyelid blinking can be there. Most commonly seen in childhood and early adolescence. Usually have symmetrical 3-hertz spike pattern. There will not be any loss of muscle tone. Sometimes automatism like eye blinking will be there. Hyperventilation usually precipitates the absence epilepsies, and patient will have poor scholastic performance due to recurrence of absence seizure. Early treatment would be beneficial, and some of the patient, like 20 to 30% of the patient, will have family history of gene mutation that are causing the absence epilepsies, particularly sodium channel mutations. Next slide. And atypical absence, in which loss of consciousness will be there, that too of prolonged duration, and multifocal structural abnormalities will be there, and EEG will show less than 2.5 per second spike and wave discharges. Okay, in typical absence epilepsy, there will be 3-hertz spike epilepsy, 3-hertz spike and wave discharges will be there in typical absence. In atypical, there is be less than 2.5 hertz per second epileptiform discharges will be there. Okay. Next slide. Atonic seizures, all of you know, it will be like a sudden loss of any postural tone, which are lasting for 1 to 2 seconds. The consciousness, most of the time, it will be preserved, but if it is impaired, it will be like within a few seconds or within a few minutes, patient will gain consciousness without any postictal confusion. This also come under generalized seizures only. Next slide. Myoclonic, as all of you know, associated with sudden, brief, jerky movements involving the part of the body, or sometimes it may progress to involve the entire part of the body. Commonly seen, as all of you know, physiologically while going to sleep, while falling asleep, and sometimes hiccups or hypnic jerks do cause this kind of myoclonic movement. Sometimes associated with metabolic disorders like uremia, hyponatremia, degenerative disorders like later stage of the Alzheimer's disease, and hypoxic brain injuries will have these kind of hypoxic or myoclonic jerks. Common diseases which are associated with myoclonic seizures are subacute sclerosing panencephalitis, that is caused by measles, CZD, as all of you know, hypoxic ischemic injuries, and progressive myoclonic epilepsies. Next slide. Epileptic spasm, these are nothing but generalized epilepsies of duration 0.5 to 2 seconds. Initially, we used to call this one as infantile spasm and salam attacks, because these epileptic spasm do involve in adult also. These are all pathological. That's why the new terminology changed into the epileptic spasm rather than infantile spasm or salam attacks. These infantile spasm and salam attacks terms are not using now. You can use the term epileptic spasm. It can be flexion type or it can be extension type. Most commonly we see flexion type associated with a sudden brief neck and trunk flexion with arm abduction, used to persist for few seconds, and continuously it used to reoccur. This is called epileptic spasm. Some of the diseases like West syndrome, in that West syndrome, we can see epileptic spasm. This is also characteristic of West syndrome, and this is also come under generalized seizures or generalized epilepsies. Next slide. Okay, then we'll go to the basic clinical approach to the seizures. Next slide. Semiology, focus, pathology, and the syndrome. Okay, next slide. Okay, why is knowing the semiology is very important? So first we can rule out the seizure mimics like syncope or TIS, and which type of seizure it is, whether it is focal seizures or generalized seizure, or whether it is having focality or non-focality. And we can know the semiology by asking the detailed clinical history, and always take history those who witness the event. Say for example, if a patient and unknown person come to the hospital, those are not seen the event, better you talk in the phone those who witness the seizure event. So before starting the anti-epileptic, make sure that the events which are happened prior were seizure like episodes. Okay, before starting anti-epileptic, make sure always, because you know the side effects of anti-epileptic cost and follow-up, and unnecessary putting the anti-epileptic in a non-seizure patient, it would be problematic both in cost and both side effect profile. Okay, next slide. Okay, localization of the focal seizure. Say for an example, if a seizure that is originating from the temporal lobe, if a seizure originating from the medial temporal lobe, patient will have automatism, aura, and epigastric aura. If lateral temporal origin is there, that time patient will have auditory hallucination, olfactory hallucinations, and vertigo. And if patient is having seizure focality which is originating from the occipital lobe, patient will have visual auras and visual blurring or colored halos also will have. In patient is having seizure focality from the frontal lobe, will have the opposite limb motor movement, jerky movement, tonic movement, head versions, eyeball movements, because of involvement of the motor strip and our eye representation area, frontal eye field involvement, that will also causes the versive head movement and versive eyeball movement. So by asking the history or by seeing the semiology, we can localize where exactly epilepsy belongs. Okay, these are the important points you need to ask. The complaints which are related to the individual lobe, whether patient is having symptoms of the frontal, temporal, parietal, occipital, you need to ask history always. Okay, next slide. I will give an example. If a patient is having a structural lesion in the right prefrontal cortex, right motor area, so ipsilateral, what are the findings which are occur in a ipsilateral side, and what are the findings which are occur on the contralateral side? Say for an example, I told you right frontal lobe involving the motor cortex, that is prefrontal cortex. The patient will have initial head turning towards the right. So what are the some of the points which are favoring? Some of the points which occurring ipsilaterally, some of the points which are occurring on the contralateral. What are the points occurring which are on the ipsilateral side? Initial light head turn and figure of 4 sign, that is flexion of the right side arm, eye blinking on the right side piloerection, right side ictal nose rubbing. These are the ipsilateral sign. If the frontal lobe involved, frontal motor cortex involved, some of the signs which occur on the ipsilateral side of the cortex, that is the ipsilateral side. What are the features which are occurring in the contralateral side? Patient will have clonic and tonic movement of the left upper limb and lower limb, paresthesias on the left upper limb and lower limb, head version movement on the left, head towards the left side, and eyeball movement towards the left side, dystonic posturing of the hand on the left side, and slow component of the nystagmus on the left side, asterexis on the left side, and akinetic movement on the left side, and postictal tart paralysis will be on the left side. If a patient is having right side lesion, these are the opposite side movement patient will be having, and the same side movement I explained earlier. Okay, any doubt in this slide?
No, sir.
Okay, next slide. It will help to lateralize the epilepsy. Then come to the localizing sign. If a patient is having epigastric aura, it indirectly indicate origination would be from the temporal lobe. If visual aura is there, occipital lobe. In a visual aura, if a complex visual aura is there, temporo-occipital junction. If acoustic aura or gastroelectric aura is there, insular cortex. If olfactory aura is there, amygdala, orbitofrontal region. If autonomic aura is there, insular cortex. If aphasia is there, dominant temporal lobe. If unilateral distal jerks are there, perirolanthic area. Unilateral somatosensory area, that involvement of the paracentral lobule, parietal lobe. Bilateral tonic posturing, that will indirectly indicate the locality will be from the supplementary motor area. If epigastric aura is there, it will again indicate the temporal lobe involvement. If gelastics, that is laughing seizures are there, again it is help to localize into the hypothalamus. So these are the few points you should always remember. If a patient says, if patient not says also, just you ask the history of aura, where from that you can localize. Aura is very helpful in the localization, particularly in focal epilepsy. So you should ask always the lobe related aura symptoms. Next slide. So okay, while describing the semiology, you need to ask the prodrome. Sometimes patient will have like chances of getting the seizures, like patient will have some of the wild symptoms of seizure occurrence, followed by patient have aura, then automatism, head movements, vocalization, dystolic posturing, tonic posturing. So depending on these symptoms, again you can classify as focal awareness seizure and focal impaired awareness seizure. If the from the focal awareness seizure, it may convert into bilateral tonic clonic. So you need to ask whether the generalization is there or not. So if generalization is there, you can label it as focal to bilateral tonic clonic or focal to bilateral tonic seizures. Then after the seizures, you need to document the postictal behavior, any postictal language disturbances, postictal memory disturbances. If the postictal language disturbance is there, you can localize into dominant lobe involvement in a epilepsy case. Okay, this is very important. You need to ask postictal language disturbances. If patient is having definitely language disturbances, you can label it as the focality of the seizure would be dominant side. Any doubt in this slide?
No, sir.
Okay. Next slide. So just epilepsy proforma, whenever you are writing or when you are seeing the patient, mention the age, handedness, age at the onset of seizures, and age of onset of habitual seizures, and this one is date and OPD. This is okay. This is a basic epilepsy proforma. It should contain handedness is mandatory, age at seizure started, and regular interval seizures when it started occurring. Those to be mentioned. Next slide. You need to ask the prodrome and you need to ask the aura. Next slide. Then during the ictal phase, during the seizure phase, you need to ask for the behavioral arrest, automatism, any abnormal movement in the extremities, posturing of the extremities, or involvement of whether patient is having any abnormal movements all over the body, that to be mentioned in the ictal phase. In post-ictal phase, you need to mention duration of the post-ictal phase. If there any thought paralysis, do mention. If patient is having any amnesia or language disturbances or headache or behavioral abnormalities, that also you should be mentioned. Next slide. During the in between the seizure attack, if patient is having any focal to generalization is there or not, whether patient is having a diurnal variation, because most of the time frontal lobe epilepsies are nocturnal, and myoclonic jars are most commonly seen in the early morning. So diurnal variation is also important. History of clusters. Clusters mean multiple episodes of seizure within a minute or within 10 to 15 minutes. If a patient is on multiple episodes of seizure, that is called clusters of seizure. This is also seen in frontal lobe epilepsies. And any history of status epilepticus or any trauma or encephalitis in the past, and present seizure frequency, and last date of seizures, or any seizure related disabilities like cognitive decline, depression, all those things are there, that also be mentioned in the history. Okay, next slide. Birth history is very important, especially in pediatric age group. You need to mention any developmental delay, social, cognitive, or any motor milestone delay is there, you need to mention. And history of febrile seizures, because the febrile seizures will have chances of reoccurrence or will have chances of converting into the epilepsies in the later part. Sometimes patient will have medial temporal sclerosis also in the future. or is there any history of seizure in the family? That will help to identify the genetic causes of seizures, or any history of consanguinity also to be mentioned. And regarding the anti-seizure medication, you need to mention what all the drug patient currently taking, which medicines patient having better response, is there any side effect related to the any anti-seizure medication, and which anti-seizure medication have better remission. So all those things to be mentioned in the drug history. Okay, next slide. And all of you should do detailed neurological examination. For any focal findings, you need to see for detailed examination, whether any patient is having any gait disturbances, sensory findings, motor findings, or any cognitive delay. All things should be examined. And systemic examination is also important, especially cardiovascular system. Most of the time, cardiovascular system diseases like atrial fibrillation, left ventricular clots, rhythm disturbances, arrhythmias, sometimes it may mimic as seizure, or it will cause a syncope. That is, sometimes it may confuse with the seizure. And even cardiovascular disorders, those will also cause us seizure secondary to hypoxia, or any decreased cardiac output, or long-standing arrhythmias that do also causes seizure. So detailed cardiovascular system examination is mandatory in a patient, in a epilepsy patient. Next slide. So basic investigation, that is your CBC, ESR, if needed, Mount test, sugars, RFT, electrolytes, LFT, ammonia if needed, chest X-ray if indicated, anti-seizure medication if a patient is having a side effect related to the anti-seizure medication, or any compliance issues, and basic investigations like MRI, CT, EEGs, and follow-up and other relevant history should be mentioned. Next slide. And these are the most common causes. In a neonate, most commonly we see etiological agents as perinatal hypoxia, intracerebral hemorrhages, trauma, infection, metabolic disturbances, drug withdrawal, developmental disorders, and genetic causes. In infants and children, commonly febrile seizures, genetic disorders, infections. In adolescents, trauma, genetic causes, infection, drug illicit, tumors. In young adults, trauma, alcohol, illicit, drug illicit, tumors, and autoimmune epilepsies. In elderly, most commonly we see secondary to stroke, or maybe secondary to the tumor. These are the common causes. And next slide, pathology would be like granulomas, tumors, infections, cortical dysplasias, focal cortical dysplasias, hypoxic injuries, gliosis, medial temporal sclerosis, autoimmune etiologies are most commonly noted. Among this, most commonly, we don't get the cause. Almost 60 to 65%, we don't get the cause. In second commonly would be vascular causes, then followed by congenital trauma, tumor, and degenerative causes. Next slide. Let us come to the differential diagnosis or close mimics. First one, seizure versus syncope. In a setting of syncope, patient will have emotional stress, any history of Valsalva menorrhea or orthostatic features, or any cardiac complaints will be there. Patient will have symptoms like tiredness, nausea, diaphoresis will be there, and most oftenly will be seen in the erect posture, and it will terminate within few seconds and without any complete loss of consciousness or any tonic-clonic movement without any post-ictal confusion. Facial appearance would be pale and duration would be less than 5 minutes without associated with, not associated with any muscle ache, or incontinence sometimes occur, but not commonly. Biting of the tongue also rare. Most commonly, tip of the tongue will be involved in case of syncope, but in seizure, most of the time lateral side of the tongue will be involved. These are the few common things you should always ask, because if you are started if you are planning to give anti-epileptic, so better you rule out syncope always, because it is also great mimicker. Next slide. And this is historical criteria. You can take a printout this and you can keep it in the OPD also. If you're having any doubt between seizures and syncope, just fill the points. This contains I think 10 points you need to fill whether patient is having the following symptoms. If the score is more than equal to 1, you can label it as seizure. If the score is equal or less than to 1, you can label it as syncope. This is very helpful. Okay, you can keep it in the emergency or in OPD. This is very important to rule out seizure from the syncope. And one more is occipital seizures and migraine with visual aura. Most commonly we are seeing in a occipital seizure, patient will have multiple colors like auras will be there. In a migraine, patient will have zigzag like and color, black and white color will be there in case of migraine. And the duration will be more in case of migraine headache. Aura duration will be more, sometimes up to 60 minutes. But in occipital epilepsy, it will be of less duration. Patient will have preceding or post the visual aura, patient will have headache. But in occipital lobe epilepsies, it would be rare. Next slide. This one only. Okay, these are the few points. As I told earlier, the colored halos will be more commonly seen in occipital, and black and white zigzag line will be there seen in migraine with visual aura. And duration is only up to minutes in occipital seizure, but in migraine aura it can occur up to 1 hour. Headache would be most common preceding or following the aura in case of migraine with visual aura, but less likely in occipital lobe epilepsies. And duration of the headache would be 4 to 72 hours in case of migraine, but in less than 1 hour in case of occipital lobe epilepsies. And other features of migraine will be there. Other features of migraine like photophobia, phonophobia, hemiparesis, hemisensory symptoms, fatigue, all those things will be there in migraine, unlike in occipital lobe epilepsies. Any doubt in this slide? This is very important. Sometimes if patient comes with multiple visual aura like complaints, don't put always in a seizure basket. Okay, you need to ask migraine complaints and migraine visual aura also.
Okay.
Okay, next slide. And one more is great mimicker is natural frontal lobe epilepsies and parasomnia. Parasomnias are nothing but abnormal sleep behavior, and NFL is nocturnal frontal lobe epilepsy. These are like sometimes you may not able to differentiate between these two. So following questions should be asked, and it should be clarified always, because both modalities, in both cases treatment would be different. In a natural frontal lobe epilepsy, duration would be very less. It used to occur in the first 30 minutes of the sleep, and multiple events used to occur, and associated with the complex behavioral problems are very less oftenly seen behavioral problems. And these are the similar like stereotypic moment. What are the moment patient is having similar kind of event that to occur regular daily basis. But in case of parasomnias, moments will be variable, and patient often recall the event in natural frontal lobe epilepsy. But in case of parasomnias, duration would be more, and later half of the part of the cycle patient will be having. In both REM and NREM, both sleep cycles also will get. And these are all very less in number, 1 to 2 events in a night it used to occur, associated with complex behavioral changes. And semiology would be different for every day, every time. The motor movements would be different as compared to epilepsies. And patient cannot able to remember the event which are happened in the night. Okay, whenever the patient is having nocturnal complaints, you need to rule out these are sleep disorders and frontal lobe epilepsies. Okay, these are the following points. These 3 to 4 points you should always remember. Next slide. And most commonly in a OPD, you people will be seeing psychogenic or functional seizure, a psychogenic non-epileptic seizure versus epileptic seizure. Very important to differentiate again the side effect profile of anti-epileptic drugs. In a psychogenic seizures, the attacks patient having will be multiple in a day, and the attacks there will not be any similar attacks. Like stereotypic movements will not be there. Patients sometimes have right hand movement, sometimes will have left hand movement, sometimes flexion, extension, dystonia. Variable movements will be there, and the number of symptoms will be more. Stressors will be there, and duration will be prolonged. And most of the time these events will occur in the daytime, but epileptic seizures can occur day or night. Injury are rare, like tongue bite, or fractures, muscle ache, are less in psychogenic seizures. And ictal eye closure. So whenever patient is having seizures, pseudo seizures, patient used to close eyes, and if you try to open the eyes again, patient will close the eyes. This will also helps you to differentiate from the epileptic seizure. Most of the time in epileptic seizures, eyes will be open, and urinary incontinence, stool incontinence will not occur in a psychogenic seizure. And abnormal movement like pelvic thrusting movements are most common in psychogenic seizures, but not in epileptic seizures. Muscle tone will be lost in a psychogenic seizure, but it will be more or normal in epileptic seizures. Post-ictal confusion again will not be there in psychogenic seizures, and post-ictal crying would be more common in psychogenic seizures. And triggers like emotional disturbances will be there, and frequency attack will be more, and interictal EEG would be normal, and stressors will be there, and most of the time presence of secondary gain history will be there, and psychiatric illness or psychiatric disturbances will be there in psychogenic seizures or functional seizure. This is a very important slide. You keep a screenshot or any printout in the OPD or emergencies, because the way of management would be different for both these kind of seizures. Any doubt in this slide? Psychogenic seizure can also be called as PNES, psychogenic non-epileptic seizure. PNES, other name for psychogenic seizures is PNES. Okay. Any doubt in this slide?
No, sir.
Okay. Next slide. Sometimes, like bilateral convulsive seizures, patient have convulsive syncope. I'll discuss the convulsive syncope in the next slide. PNES, as I told, like psychogenic non-epileptic seizures. And concussive, like post-traumatic due to the brain concussion, herniation, sometimes patient has tonic posturing that also sometimes mimic as a convulsive seizures. And one more is hypereclepsia. Anybody define what is hypereclepsia? Cataplexy, catalepsy. Can anybody define? Okay, hypereclepsia is nothing but exaggerated startle response that also sometimes mimic as tonic posturing. In absence seizure, sometimes you may label it as daydreaming or PNES. In myoclonic seizure, sometimes later stage of the syncope patient will have myoclonus. During sleep also patient have myoclonus. So sometimes you may mislabel. And what is the catalepsy and cataplexy? Can anybody define?
Sudden loss of tone of the person in narcolepsy is known as cataplexy.
Cataplexy, good. Catalepsy?
Uh, mm,
In this, you can mold the patient like any posture. In schizophrenic patient, you can see, if you keep the posture in a flexion, patient will be having persistent. That is catalepsy. And this is cataplexy is close mimicker of atonic seizure. In this also, sudden loss of tone will be there. But most of the time in cataplexy, it will be triggered by any startle response or any abnormal laughter or any crying episodes will always precipitate the cataplexy, and also associated with the other features of narcolepsy. Okay. In tonic seizures, again, you need to differentiate from the dyskinesias, hypereclepsias, breath holding spells, and due to the pain secondary to extreme pain disorders. And epileptic spasm, sometimes it can be confused with the benign sleep myoclonus or infantile clonic also. Infantile colicky pain also sometimes mimic as epileptic spasm due to the involvement of abdominal muscles. Next slide. Convulsive syncope and epileptic seizure, because sometimes in the later part of the syncope, patient will have clonic movement or tonic movement, sometimes myoclonic movement. That also you may be mistaken for epilepsy. So you need to ask for detailed history. In a case of convulsive syncope, the myoclonus is used to occur after the complete loss of consciousness. These are the arrhythmic jerks used to occur very less in number, like oftenly they're telling less than 10 in number, and duration of less than 15 seconds, in which the eyeball upward movements will be there and tip of the tongue will be involved, and post-ictal period there will not be any confusion. Patient will have only fatigue. So convulsive syncope and epileptic seizures also very important to differentiate. Okay. Next slide. And one more is absence epilepsy and focal impaired aware seizure. Don't use the term of complex partial seizure, better use the term focal impaired aware seizure. Okay. In a focal impaired aware seizure, age of onset would be late or earlier part will be there, and neurological examination will have some findings due to the involvement of focal cortex or any hippocampal lesions. RS will be common, not in absence epilepsy, and duration up to minutes, sometimes up to minutes in case of focal impaired aware seizure, and automatism will also be there. There will not be any provocation factor like hyperventilation in a setting of focal impaired seizure, and frequency are very less as compared to absence epilepsies. Post-ictal confusion will be there, and EEG finding characteristically you can differentiate from the EEG, and neuroimaging in that focal lesions will be there in case of focal impaired aware seizures. Okay, these are the few points, because the drugs which are using to treat the focal impaired aware seizure and absence epilepsy is entirely different. So you should be knowing the clinical history and background, because treatment is different, prognosis is different, age of onset is different. So better you should ask detailed history. Always in a seizure patient, you should ask detailed history. Next slide. And sometimes if a patient is having seizure also, sometimes we may misdiagnose the seizure. Say for example, sudden onset amnesia, episodic amnesia, it can be confused with transient global amnesia. In transient global amnesia is nothing but sudden loss of memory, like transitive fugue. Patient will have completely lost in memory for a period of at least 24 hours due to the involvement of bilateral hippocampus, maybe second to stroke or some other events. But the EEG would be helpful for the diagnosis. And second one is ictal fear and anxiety. Sometimes due to involvement of insular cortex or hippocampus, patient will have fear and anxiety. So it may be mislabeled as anxiety disorders. And sometimes nocturnal seizures like nocturnal frontal lobe epilepsies may be mistaken as parasomnias. And absence epilepsy can be mistaken as daydreaming or ADHD, learning disabilities. And sometimes frontal lobe seizures due to the hyperkinetic movement involvement of like kicking or any thrashing movement or tilting movement, behavioral issues, sometimes mistaken as psychogenic events. So very important to ask the history, and better to witness the event, or we have to tell the patient to make a record and send to the WhatsApp, or if they're coming to the OPD, better to take a video and come. So in that setting, we can easily differentiate whether patient is having PNES or frontal lobe seizures. And sometimes seizures may cause bradycardia and syncope. So because all are some of the channelopathies that do involve cardiac tissue and neuronal tissue that causes the rhythm disturbances, that will also causes asystole. So we sometimes mistaken as heart block that is causing the seizure. Initially we'll treat the only asystole. So seizures do causes asystole also. Sometimes confusional spells and non-convulsive status epilepticus can be mistaken as dementia, especially in a Lewy body dementia case. We will mistaken as like patient is having confusion cell, that is not seizure. Like that, sometimes we make a confusion. So better rule out all these mimicker, because management would be entirely different. Can anybody define what is non-convulsive status epilepticus? Any gross idea?
There will be just twitching of eyelids or just the movement of the lower jaw, and then patient will be in a state of continuous status of epilepticus without any tonic-clonic movement.
Good, excellent. This is very important, because most of the time in a ICU, comatose patient comes, you evaluated MRI, CT, venogram, metabolic parameters, everything is normal. Still patient is having these kind of comatose movement. Better in that setting, you need to order a EEG. EEG in a EEG will be having continuous spike and wave discharges of at least more than 2.5 hertz frequency that are well responding to anti-epileptic drug. That will be diagnostic of non-convulsive status epilepticus. As a physician, you should always be knowing the non-convulsive status epilepticus and status epilepticus, because here giving a simple anti-epileptic drug, you can completely reverse the condition. Okay, so non-convulsive status epilepticus is great mimicker. So whenever comatose patient, you are not getting any clues from any investigation, order a easy, give a trial of midazolam or anti-epileptic drug and see for the response. Okay, this is a table from Harrison. Again, just a brief line. The close mimickers would be syncope, psychogenic event, metabolic disturbances, migraine, vascular events, sleep disorders, movement disorders, and in a case of children like breath holding spells, apneas, night terrors, and sleep disorders sometimes mimic a seizure. So take a detailed history, and the key points for individual complaints. So plan accordingly. Sometimes because after detailed evaluation of a seizure, we don't get any causes. As I told, around 60 to 65% of the patient, we don't get any cause even after extensive evaluation. So better you take a detailed history. So before you are giving the anti-epileptic drug, take detailed history and do proper diagnosis. Then only you start the anti-epileptic drugs. Okay. Next slide. So before ordering the investigation, make sure that whenever you are ordering the investigation, don't write like MRI brain. You should write MRI brain with proper epilepsy protocol. What is epilepsy protocol? If you have a center having 1.5 Tesla MRI scanning, the sagittal sections of the MRI should be around 5 mm thickness, axial 5 mm, and coronal section should be 2 mm to look for the hippocampus and detail cortex. In a case of 1.5 Tesla, in a case of 3 Tesla, if you are having, you can order axial T2 weighted images of less than 2 mm thickness and flare images of 4 to 5 mm thickness and T2 weighted images of 3 mm thickness. These are the epilepsy dedicated protocol MRI. So whenever you are writing MRI for epilepsy patient, better always write epilepsy dedicated MRI or epilepsy protocol MRI. Okay, don't write just MRI brain and send. Okay, next slide. You can order MRS also in a case of medial temporal sclerosis, NCC versus tuberculoma that are causing the seizures. In a case of medial temporal sclerosis, there will be decrease in acetyl aspartate choline ratio. That will also indirectly help you to the diagnosis. In a special setting, you can order MR spectroscopy also. Next slide. So one more thing is EEG. So whenever you are ordering the EEG, don't write simply as EEG for seizure. So you should advise the patient should not sleep more than 4 hours just in the previous night, because if you give a proper sleep, if you advise the proper sleep for the patient, there will be less chances of easy yield to identify the seizure. So if a sleep deprived, the easy finding should be better always. So tell the patient to sleep only for 3 to 4 hours. If you have, say for example, if you're planning easy for tomorrow, you should tell the patient, attend or a patient, better sleep for only 3 to 4 hours, and rest of the 4 hours patient should be awakened. Okay, because sleep deprived EEGs will carry good yield. Okay, and whenever you are ordering the EEG, you should write always sleep awake pattern both EEGs, and minimum 40 minutes EEG you should write. In 40 minutes, at least 20 minutes awake and 20 minutes sleep pattern should be there. Okay, and only single EEG is not enough to identify the epilepsies. Sometimes in the book this says at least for 3 readings of EEG, 3 times if you do the EEG in a proper epilepsy protocol, you have chances of getting the yield of 90 to 94% sensitivity to identify the proper epilepsy. So whenever you're writing sleep deprived EEG, at least only 4 hours sleep, and EEG duration should be more than 40 minutes. In that 20 minutes should be awake and 20 minutes should be sleep, and proper calibration should be done, and other activities like eye opening, eye closure, photosensitivity, hyperventilation, all those procedures should be done by the technician. Then only you can comment or you can diagnose the condition. So you should be, don't write next time onwards, don't write only EEG. Okay, any doubt in this slide?
No, sir.
Okay, next slide. Other investigation we rarely use, PET scan, especially in focal epilepsies, refractory focal epilepsies. We can get the PET scan, we can demonstrate the hypometabolic areas. If the hypometabolic areas are more, if patient already taking 5 to 6 anti-epileptic, that time we can refer the patient for epileptic surgeries. And MEG is magnetic resonance. This is like a EEG we can do under the MRI. This is called MEG EEG. These are I think in Karnataka only Nimans people are doing MEG EEG. And invasive EEG is nothing but we can put the electrode directly on the cortex by using the electrode, directly putting the electrode into the cerebral cortex and recording the event. And MRS, as I told earlier. And third one is functional MRI, and last one is video EEG. These are the investigation. If you don't get any clues from the previous investigation like basic MRI, epilepsy protocol MRI, and EEG, you can go ahead with the next higher end investigation. Next slide. So, okay, while writing the diagnosis of epilepsy, okay, first you define patient is having whether he is having seizure or epilepsy. Okay, so if you identify this as epilepsy, definition, as I told earlier, if a patient is having unprovoked seizures of number more than 2, like over a duration of more than 24 hours, and chance of reoccurrence of the seizures in an unprovoked seizure, like more than 60% of reoccurrence of seizure over a period of 10 years, or if a patient is having any epileptic encephalopathy or epileptic syndrome, that time also you can label it as epilepsy. So while writing the epilepsy diagnosis, there are 5 axes are there. First one is semiology and type. Second one is which epileptic syndrome it belongs. And third one is etiology. And fifth one is associated problem. Say for an example, if a patient is having right prefrontal cortex, left prefrontal cortex, some lesion is there, he is having the seizures of right focal motor seizure. So you need to write the diagnosis like right focal motor onset to bilateral tonic-clonic. Right focal motor onset to bilateral tonic-clonic with frontal lobe epilepsy, predominantly lateral prefrontal cortex dominant lobe involvement of structural etiology associated with depression or cognitive delay. So whenever you are writing the epilepsy diagnosis, you need to write completely seizure semiology, seizure type, ILAE classification, etiology, and associated problems. Okay, any doubt in this slide?
No, sir.
Okay, next slide. Okay, syndrome, as all of you know, Dravet syndrome, West syndrome, LGS, Lendo-Klipner syndrome, epileptic myoclonic syndrome, all those things are particular epilepsy. If a patient is having particular epilepsy like infantile spasms as seen in West syndrome, if mixed kind of seizures, LGS, if aphasia is there, Lendo-Klipner syndrome. So particular clinical features will be there, particular EEG patterns will be there, natural histories will be like precipitating factor. In case of Dravet syndrome, fever will be patient having precipitated, and response to anti-epileptic drug and family history will help you to identify the particular type of syndromic epilepsy. This most commonly seen in pediatric age group. I think we no need to see in detail about the epileptic syndromes. Okay. Next class, I will just show the one flow chart so that from the single flow chart we can make out what are the clinical features of epileptic syndromes. Okay. Next slide. So approach, like you see the patient of epilepsy, you ruled out all the epilepsy mimics. Finally, you confirmed it is epilepsy only. You start with the monotherapy, optimize the monotherapy. Even after you choose the proper anti-epileptic. What is for the focal seizure or generalized seizure or myoclonic seizure or infantile seizure? You label and give appropriate anti-epileptic. Escalate the optimum dose of anti-epileptic even after patient is having seizures, means you can add on the therapy. Even after add-on therapy, patient is having seizures, again you can reevaluate the video EEG. In that, the ictal waves. Say for example, if a patient is having seizure, meanwhile you put him on the EEG, that would be helpful that ictal EEG can be recorded. So whether that is correlating with EEG findings or that not there. If that is correlating, so you can label it as easily it is an epilepsy. If it is not correlating, so no need of revising the therapy. Okay, after doing the video easy, if you find out that is particular epilepsy and you go on escalating the anti-epileptic drug, as per the textbook they are saying up to 5 anti-epileptics of maximum dose you can give. Even after that patient is having seizures, means you can try the other modalities like vagus nerve stimulation, keto diet, other neurostimulation techniques, or epileptic surgery. On a PET scan or a functional MRI scan, if you get any focal lesions like medial temporal sclerosis or focal cortical dysplasias or cortical tumors, in that time also you can offer the patient for surgery. If a patient is not an ideal candidate for surgery, you can give other options like vagal nerve stimulation, keto diet, neurostimulation, or any corpus callosum method. Any doubt in this slide?
No.
Okay, next slide. So first aid, this should be taught by the doctor. You should tell all the patient and patient attender during the attack, be calm, don't be panic, and loosen the cloth, especially around the neck, and should always be in the left lateral position, because aspiration risk chances should be less in a left lateral position, and head should be on the lower part as compared to the body, and better to clear the vomitus or any secretion from the mouth. Don't insert any objects into the mouth, or don't give any fluids or drug orally, and better you stay along with the patient till the consciousness is till he or she recovers. Okay, these are the basic needs. You should always educate the patient in any seizure patient, educate the attender and patient regarding these points. This is very important. What precaution patient or patient attender should take during the seizure attack. Okay, next. This is a basic epilepsy proforma. In a busy setting, you cannot write everything. You can write just age of onset, age of presentation, prodromal aura ictal symptoms. Is there any secondary generalization or history of any status epilepticus? Birth and developmental history, as there any family history, and which all the anti-epileptic are tried, best anti-epileptic drug, and current anti-epileptic patient is taking, and which classification under it will come, what are the seizure type and epilepsy syndrome, and what are the investigation has been done. In a 2 pages, you can briefly write in a busy OPD schedule. You can use this sheet. Okay, just a copy from this one, and you can write in the OPD slip also. So it would be helpful for a follow-up patient. Next slide. So take home message. Detailed history is very important. You need to identify the precipitating factors and associated condition. So identify the pathology. If possible, make the syndromic diagnosis, investigate accordingly, and start the drug. Better start with the monotherapy. If needed, you can add on or you can modify. And along with that, you need to tell the patient for a lifestyle modification, like if patient is having any addiction to alcohol or any tobacco, that to be modified. And socioeconomic status or any social issues also should be addressed. Next slide. Okay, few of the slides I have added in the last after this I have added few of the slides. If you are interested, go through that. That is not required for MD medicine student. If you want, you see those slides. Another 10 slides I have added. Okay, if you are interested, you go through. Otherwise, whatever the slides I shown prior, that are all enough for you people.
Okay, sir.
Okay. Any doubts?